Hello. Hello, Sudeep Das is here.
Yes, sir.
Good evening.
Good evening, sir.
He is not yet connected to audio, I think.
Sudeep ji, good evening.
Hello, Sudeep, please allow screen sharing. Right now, screen sharing is disabled. Mr. Tapas?
Don't worry, madam. Everything will be all right. Don't worry.
I don't know if they don't allow screen sharing it yet.
Yes, yes.
Dr. Pandit, please try it out.
Right. Yeah, it's fine now. Fine.
Yes, madam.
Hmm.
You put in slideshow mode. Yes. Perfect.
Right. Chalo. Fine.
Hello.
Hello.
Hi, Deepika.
We can hear you now. You want to try
But
to screen your share, do a screen
can
share?
I share? मैं share
Yeah.
screen करूं अपना?
Yeah.
दिख रहा है मेरा?
Not yet.
दिख रहा है अब?
Yes, madam. We are
Yes.
able to see.
Okay, wonderful. So should I stop sharing now?
Screen on full screen.
You want me to run it a bit?
Full screen, ma'am.
Yeah.
Yes.
Okay, perfect. So I stop sharing now. How do I stop share? Okay. Yeah. I've lost touch of. Is my screen gone now?
Yeah, yeah.
Yes.
Yeah. So now when I need to share, I have lost proficiency in this. Okay, now I know what to do. Right.
Good evening. Hello, Deepika. Good
Good
evening.
evening.
Good evening, sir.
Ah,
Good
good
evening, sir.
evening. Good
Good
evening,
evening,
Dr.
sir. Good
Kumar.
evening.
Good evening,
Good
sir.
evening,
Good
Dr. Murugan, and thank
Good
you
evening.
for
Thank you.
Yes.
joining.
Thank you,
Hello,
sir.
hello, Nina.
Good evening,
Good
sir.
evening, and thank you
Hi.
for joining.
Good evening.
Thanks for
Hello, Deepika.
but I don't like your timing. इतना late. It's well past. मैं तो zoned out हूँ वैसे ही तो मेरे से कोई गलती हो जाएगी तो कोई problem नहीं है मेरे तो I'm sleep talking now.
Sunday, actually, people are busy in the evening, na? So, so busy shopping or busy going out with the family. So that's why we kept late, so that people come back before, their shopping or outing is done. That is the purpose of keeping it bit late.
I mean it's so late. Yeah.
Sudeep, sir. Good evening.
Can't hear you.
Sir, good evening, sir.
Sudeep, you are muted. You are muted.
Unmute. Yes.
Sudeep, you will introduce the, faculties, no?
Audio is not there. You'll have to remove
Sud-
your headphones.
Everybody has such beautiful backdrops, no?
Sudeep, what happened with your audio
Audio,
system?
you'll have to log out and re-log in with audio. नहीं है audio.
Sudeep, can you hear?
He can hear. That's why
So
he's talking, but he can't hear you.
you leave, then you log in.
Not here.
No, we are not able to.
How we can hear you?
Now you are audible, sir.
Okay. So let me relog out.
No, you are
Sir, now you
logged
are
in
audible,
now.
sir.
You are
Just a
okay,
minute.
Sudeep. You are good. We can
Now
hear
we
you
can
now.
hear you finally.
Now
Okay.
it's fine. We
Now
can
you are
hear
audible,
you.
sir.
Okay, I
Right.
put
Sudeep,
up my own. I put my own voice only. Remove that. Yes, system.
Yes, sir.
listen one thing. Sudeep, you will introduce the faculties, so?
Sure.
Okay.
Where is Kaushik? Let him ask him to join first.
Dr.
Stop.
Bharti is also there.
I'm
Kingshuk
trying.
has not joined. The Amul baby has
Bharti is there.
Rakesh is joining.
He's joined, I think.
I'm trying.
পরের দিন থেকে আমরা একটু 8:30 করি। Let us do at 8:30.
ঠিক है,
I think that would be the right time.
ठीक. Even today, I was also feeling the same, actually, frankly speaking, that we
I'm
can do
calling
it
up
from
Kingshuk.
8:30.
Only
मैं तो
Welcome.
वैसे ही zoned out
Well,
हूँ.
welcome,
I'm going to
Rakesh.
be sleep talking.
Rakesh Bharti has joined.
Yes,
Yeah.
yes.
Good evening, Rakesh ji.
Rakesh
Good
Bharti
evening.
पर नहीं ला रहा है.
You are trying home.
Mohan Kumar sir
Yes, sir. I joined, sir.
have joined.
Yes, sir. I am now joined here, sir. Yes, sir. We are
Only
joined,
our
sir.
Kingshuk has not joined here. And Rakesh Bharti.
He's joined.
I'm trying to contact Kaushik.
Dr. Bharti का hello सुन लेते हैं. Dr. Bharti?
Yes, can you hear
We
me?
can. You are
Yes.
audible.
Yes, sir. We are hearing, sir. Yes, sir.
I'm
Good
just
evening,
trying to
Dr. Bharti's
sound.
chamber.
Yeah, you've been here.
Rakesh sir. Good evening.
I had
Sir,
been
good
there, na? Dr. Bharti's
Good evening.
chamber. At the privilege of
Yeah,
coming.
get to see Dr. Deepika, Dr. Nina, Dr. Murugan, all
sir.
in my chamber. Sudeep, you have
Yeah.
come.
Planning. We will plan surely.
Today we
Ah,
have right now
Sudeep, you
480
come.
audiences.
480
Oh.
audience.
The audiences have registered. They will join shortly.
Yes,
So we are going to have a good year.
Kaushik is joining. There was some exigence in the family, so that's why he got delayed, late. So he is joining right now.
Dr. Kingshuk Chatterjee.
King Shuk, I'm just calling up. Not we can pick the call.
Then
Let me
even,
see.
even if Kingsuk joins late, no problem, na.
The
So
King Shuk will be in the second half. So
Kingsuk
first is
will be in
Madam
the
Sec. He will
second
join
half.
shortly.
Kingsuk is one of the panelists, no?
Uh-huh.
Right. So that is after Nina's lecture only.
Mhm.
So at least half an hour, after half an hour.
I'm calling him up. Let me see. No, State Secretary, he should be there. Why he's not there?
But we have to start it on time. Sudeep.
We'll start sharp at time.
10?
After 9.
सुदीप, not 10. मैं तो वैसे ही मैं सो रही हूँ. 9 o'clock.
No,
9 o'clock, 10 will finish. 10:05. We didn't exceed a single minute last time also.
Great.
Max to max, 10:05 will finish.
Somehow I can't see anyone now.
I'm seeing you fully.
Ah.
I'm seeing
You
you
all have
fully.
become Mr. India.
No, you're not Mr. India. I'm sending you a photo. Now you are seeing because that time now Deepika is on the screen, so Deepika cannot see.
yes, Kaushik has joined.
Dr. Lahiri. Good evening, sir.
Good evening.
Welcome, Kaushik. And
I
we are going to start in next 2 minutes time. Okay?
Good evening, sir.
Am I audible?
Good evening,
Yeah.
sir. Yes, sir.
Yes.
Audible, sir.
Yes, sir.
Yes. You are audible.
Yes, everyone. Hello, Dr. Vati.
Hi, Dr.
Hello, Madam.
Hi,
Yes,
hi.
It's good.
Dr.
Yeah.
Morgan. Hello, Dr. Kumar. And Dr. Deepika.
Yes,
Sudeep, sir. Sandeep Anda.
yes, sir.
All the full team.
Getting young day by day.
Oh, me.
Getting Kaushikda. Getting young
Ah,
day by day, and
thank you. Thank
just before the presidential election is losing weight.
Yeah.
you. No. This is not the forum to discuss. This is not the forum to discuss. I'm
No,
sorry.
I'm not discussing. I'm just
Thank you.
joking.
Thank you.
I'm just joking.
So, Kaushik, the flow is that you will first introduce Dharma Adhyayan. Okay.
Yes, sir.
Then
We're 9. Let us.
this will followed by
Then I'll give it to you.
just give it to me. Then I'll give it to Sudeep. We'll do these things very quickly. No, it is not yet 9. It is
Just 2 minutes. I
8:59.
think don't be yet 2 minutes each, and we'll finish it off.
1 minute
And
each. Not 2 minutes. 1 minute each.
Okay.
and
Still better.
YouTube and Mr. Abhilash and
It is just 9.
Dr.
Let us go.
Abhishek.
Let us go on web.
So
Abhilash.
do I have the link to share on Indian Journal of Dermatology and all WhatsApp things, Abhijit? So anyone from the back team?
Abhilash is there. I don't know.
Anyone from the back team, can you share me the link which I'll have to share on Indian Journal of Dermatology Facebook group as well as to all the WhatsApp group so that everyone can the YouTube. Okay, Abhijit, thank you. I have received. Thank you.
We have given in the group, sir.
Okay, so I'll just give it to.
Tapos has joined. Tapos, are you there?
Taposh is there. Taposh is there.
Yes, sir. Yes, sir.
Suppose, as I told you earlier, send me 2,
Yes,
3
sir. I'm
photos.
sending. I'm sending.
Okay.
So can you go ahead?
Yes,
Sandeep
please. Start it.
Okay. Welcome to Dharma Adhyayan, Session 1, Episode 2. And this is, as you know, is another flagship project from IDVL West Bengal and directly under the IDVL West Bengal Academy. And why we are telling the flagship project? Because West Bengal state branch is known to have several flagship projects since last 50 years. And because this is one of the founding branches of IADVL, we have given not only the first president of IADVL, we have given many things like before the brand started, before IADVL started in its own form, we had the Dermatology Society of India, our Indian Journal of Dermatology for last 70 years. And also with the Madras branch, we have the wonderful heritage of continuing medical education every month. We are still going ahead with our monthly clinical meetings since 1961-62. So that is for last 62 years we are going ahead with this. So to add to this heritage, under our academy head, Dr. Sudeep Das, and also the president-elect, who will be the president next week, actually, Dr. Sandeep Andhar, we have started a very prestigious thing since last month, and I'm very happy that Dr. Sudeep has very correctly touched two issues which we rarely discuss. Last month we discussed leprosy, and this month we are discussing sexually transmitted infection. These things are rarely actually approached or discussed in our IADVL forum. So I'm very happy and must congratulate Sudeep for highlighting this. And so with these few words, it's over to Dada Shradipanda, the Dada of Bengal Dermatology, the Dada of Indian Dermatology. Shradipanda, please take over.
Thank you very much, Kaushik. Welcome, esteemed colleagues and friends. At the very beginning, I can see the joining is more than 100. So I think that proves once again the morning shows the day. I'm sure that in the next 5-10 minutes, we'll have a good number of people who have joined.
Within 3 minutes, 114.
Yes.
It's terrific, terrific.
So we have a very good topic, usually not much discussed in dermatology forum, but it is so very important in practice. And today we are very lucky to have the most erudite and expert colleagues of us who will be sharing knowledge on this topic, STI, sexually transmitted infections. The speaker is Dr. Nina, the moderator, Dr. Deepika. Welcome, Dr. Nina. Welcome, Dr. Deepika. And the panelist is Dr. Rakesh Bharti, Dr. S. Murugan, and Dr. Kumar. Of course, Dr. Kingshuk will be joining in a short while from now. He must have been stuck somewhere. Our, Secretary General of IADVL West Bengal chapter. And with this, I hand over the platform to Sudeep, Dr. Sudeep Das, our Academy Chair, to introduce the faculties. Over to you, Sudeep.
Well, first without any much wasting time, I'd invite my teacher, Dr. Nina Khanna, to deliver a talk on STI, and then followed by another of my friend come sister, Dr. Deepika will take over as a moderator. And I have with me two of my STI colleagues in STI Association. Deepika is also is hosting the STCon, we all know. And along with that, Dr. Murugan is there. Welcome, Dr. Murugan. Dr. Mohan Kumar is there. And Dr. Rakesh Bharti, as always, a friend, is there. And the fourth person, Kingshuk, is still not there. And obviously, Kaushik Da, as the president of IADVL West Bengal, the current president, and Sandeep Andhar, as the president-elect, will take us here. Sandeep Andhar, as always, already told, the Dada of West Bengal dermatology, not only the West Bengal dermatology, probably the Indian dermatology. Thank you. Let us start. Welcome, Dr. Nina. Madam, please share your screen.
Just sharing it.
Yes, perfect.
Okay. So Sudeep gave me the topic of genital ulcer management, what has changed in 2022, but I tweaked it a bit because not many months have passed under the bridge of 2024. So I have changed the topic to what has changed recently. Now, we know genital ulcers, the commonest cause are sexually transmitted infections. So you have HSV1 and HSV2, HSV2 more frequently. Then you have syphilis, then you have chancroid and LGV very rarely. And now almost eradicated granuloma inguinal or donovanosis. Then you have the non-STIs, causing genital ulcer, that's tuberculosis, amoebiasis, leishmaniasis, to name a few. Then you have non-infectious causes. So trauma is one common cause. Fixed drug eruption, Behçet's, neoplasms, Crohn's disease occasionally causes genital ulcers, and Lipschutz ulcers. So my topic is mainly on sexually transmitted infections and the recent trends in genital ulcer disease, the causative agents. These are the studies reported in 2023, and some of our work varying from 2019 to 2022, we have found that herpes genitalis or genital herpes is the commonest cause of genital ulcerative disease. Now, this is a very busy slide, but this is the WHO algorithm of managing a patient with genital ulcer. Now, so dissecting it simply, so if a sexually active person presents with an ulcer or an erosion in the genitalia, it's a good idea to assess the patient's medical and sexual history to assess the risk of STIs. Now, this is a box of the history taking in patients with genital ulcer disease. These are the 5 Ps of the sexual history, which WHO recommends. So you have to look at the partners, the practices, the protection from STIs, past history of STIs, pregnancy now in the patient or the partner, and the intention to become pregnant. Then you do a physical examination of the anogenital area. And if you have a quality assured molecular test not available, or the result is not available on the same day, then you treat the patient syndromically. So how do you manage the patient syndromically? So you see if there are vesicles or the patient has history of vesicles or a recurrent ulcer at the same site. If the answer to that is no, then you treat for HSV, that's herpes genitalis, and for syphilis, and chancroid if geographically chancroid is prevalent in that area. How do you manage the patient syndromically? So if the patient does not have vesicles and ulcers at the same area, then you treat the patient for herpes genitalis or for chancroid. And if the patient has not received treatment in the past 3 months for syphilis, then you add the treatment for syphilis. So effectively, you treat the patient for herpes genitalis, syphilis, and chancroid if the geographically chancroid is prevalent, unless the patient has received anti-syphilis treatment in the previous 3 months. If the patient has received such a treatment, then you just treat for herpes genitalis and chancroid. You offer HIV and syphilis serological testing and preventive services as recommended in the guidelines, and you ask the patient to come back for follow-up in a week's time. If, however, you have quality assured molecular test results available the same day, then you treat the patient depending on the result of the test. And again, you offer HIV and syphilis serology and the preventive services as recommended in the guidelines and ask the patient to come back for a follow-up. And often enough, you have quality assured molecular tests available, but the result is not available the same day. In such a case, you treat the patient syndromically and you tweak the treatment appropriately when the molecular tests come. And again, you offer HIV and syphilis serological testing. Now, these are the WHO guidelines. Now, what are the quality assured molecular tests which need to be done in a patient with an anogenital ulcerative disease? So routinely, you do testing for genital herpes and syphilis. In areas where LGV is reported, you add a molecular test to rule out chlamydia trachomatis and treat appropriately. And of the tests available, you can either do a generic chlamydia trachomatis test or you do a strain-specific NAT. In case there is chancroid reported in that area, then you do a molecular test to rule out Haemophilus leukemia and treat the patient appropriately. Now, we must remember that there is no FDA-cleared NAT for H. ducrei, but you have lab-developed CLI-verified tests available for the genital specimens. Now, a word about POCTs. Now, these are point-of-care tests to be done in sexually transmitted infections. Now, the importance of them lies in the fact that they ensure same visit results so as to start treatment at the primary care facility, especially in low and middle income countries. Now, the basic requirements of POCTs initially were acronymed as assured, have recently been renamed as reassured, which indicates there is real-time connectivity. So that means the result comes immediately. There is ease of specimen collection. They are affordable, sensitive, and specific, user-friendly, rapid, equipment-free, and delivered immediately. Now, this is the reassured diagnostic criteria for POCTs described in 2023. Now, there are other challenges in patients in countries of low income and middle income countries. These are environmental challenges. You have poor resources, few trained staff, and paucity of financial resources. Now, the molecular tests in syphilis hold promise in the window period before seroconversion, but none of them are FDA cleared. Most of the lab-developed CLI-validated PCRs for genital ulcer disease for treponema pallidum are TP45 or Pol A gene based, and they have a sensitivity of 72 to 95% and a high specificity. You also have a very recently a TMA assay, which is very sensitive and specific for detection of treponema pallidum. Now, serology in syphilis, we have conventionally followed the traditional algorithm, but more and more guidelines are indicating that the reverse algorithm may be more beneficial. And the recent guidelines, CDC guidelines, and the NACO guidelines, which are likely to be released soon, have recommended the following of the reversed algorithm. Now, some of the POCTs available in syphilis include the syphilis health check, which is done on the whole blood. And this is an FDA cleared and CLI waived lateral flow assay, which has a moderate sensitivity, but a high specificity. Then you have the dual path platform for HIV and syphilis, which is now going to be incorporated in the NACO guidelines. Now, this is the rapid multiplex immunoassay, which is FDA cleared, and you can take the sample directly from the finger, and it has a high sensitivity and specificity. You have several other point of care tests available with variable sensitivities and specificities. Now, these are recent guidelines of CDC on how to do serology in syphilis. Now, as I mentioned earlier, the dual path platform is likely to be adopted by NACO in the 2024 guidelines. When you look at the molecular tests in genital herpes, you have multiple FDA cleared HSV NAT assays available with a high sensitivity and specificity. But it's important to remember that failure to detect HSV by NAT, especially in older lesions or in the absence of active lesions, does not rule out herpes genitalis. You also need to further type the amplicons to determine whether it is HSV 1 and 2. You have now near POCT NATs available. Now, these are going to be using the COVID testing machines. So you're going to repurpose the COVID testing machines. And now you have CRISPR available, which is has a shorter TAT, low cost, easy to use, and no expensive equipment. Now, this has been validated recently. So this is a 2024 publication. Now, looking at serology of genital herpes, we know that you have type-specific IgG, which can be done either in the lab or as a point-of-care test. Now, presence of HSV2 antibody indicates anogenital infection, and it has a sensitivity of 80 to 98%, but may need to be repeated in 12 weeks' time in recent HSV2 infection. It's important to remember that all guidelines indicate that this should not be done in asymptomatic patients who've never had genital lesions unless the partner has genital herpes. It may be indicated in recurrent or atypical genital lesions or in patients with typical lesions who have a negative HSV PCR or culture or the tests are not available. It is also indicated in high-risk patients, those patients who have more than
10 lifetime sex partners or patients who are HIV positive. Now, one of the most used, or I should I say misused test is the herpes select, because it has a very poor specificity of about less than 60%. So it needs to be confirmed. And if confirmatory tests are not available, the patient needs to be counseled about the limitation of the test because of the false positive. It's important to remember that. I'm sure most of us have encountered patients who are asymptomatic otherwise, but come to us with a high risk behavior and HSV serology positive, and you do not know what needs to be done with these. And these patients are really anxious, and some of them have a lot of social and psychosomatic problems. Now, again, HSV1 type specific IgG should not be performed routinely in patients with STI, because this is more difficult to interpret than the HSV2 serology. It may be done in a patient who has typical recurrent genital herpes, but has a negative HSV2 serology, which ideally needs a NAT confirmation. Must remember that HSV1 isolation is increasing in genital ulcer disease. The type common IgM is not recommended, as may be positive due to recurrent genital herpes or due to labial herpes as well. Now, we've spoken in terms of the NATs for the PCRs for individual STIs causing genital ulcers, but we also have a multiplex PCR available, and this is our work from AIMS, where we found that the multiplex PCR was much better than combination of culture and serology or a dark ground elimination isolation of Treponema pallidum. Now, these results have been validated by a larger study. Ours was a study on 50 patients with genital ulcer disease. A recent publication indicated that 40% of the genital ulcer disease was caused by HSV2 and a quarter were caused by Treponema pallidum. However, HSV1 in this study was at a very low. Now, we also have many commercial multiplex PCR. Now, you have this assay available, which not only looks at Treponema pallidum, but also looks at herpes simplex 1 and 2, LGV, varicella zoster, and cytomegalic virus. And there is no conflict of interest. I'm not promoting these products at all. Now, in a patient with genital ulcer, abstinence is an important thing, at least till the activity of the ulcer has subsided. All patients with genital ulcer disease should have at least a serology for syphilis, HIV, hepatitis B and C, and any other molecular test or other tests which are available depending on the where the patient is presenting. The patient should also be offered Hep B and HPV vaccine depending on the serology report and age of the patient. The patients who are HIV negative should be offered HIV PrEP and retested for HIV at 3 months. Now, this is the CDC recommendation. Now, special consideration in syphilis, penicillin G is the treatment of choice. The patient needs to be desensitized if the patient is allergic to penicillin. Partner management in syphilis is very important. Persons who've had a contact less than 90 days in a patient with syphilitic genital ulcer disease needs to be given presumptive treatment for early syphilis, even if the serology is negative. So this is very important. However, if the contact is more than 90 days before the diagnosis and the serology is positive, the treatment should be based on clinical features and evaluation of the stage of syphilis. If the patient's serology is negative, if the contact serology is negative, the contact need not take any treatment. If the serological results are not available immediately or the follow-up is uncertain, the sexual contact needs to be given presumptive therapy for early syphilis. The treatment with a co-infection of HIV is the same for genital ulcer disease due to syphilis. Now, coming to counseling for genital herpes, it's very important. Now, these are recent guidelines which have been published in medical clinics of North America. You need to discuss the natural cause of the disease. You have to counsel the patient regarding recurrences, regarding the viral shedding, more in the symptomatic, but also in the asymptomatic period. At this there is increased transmission. The asymptomatic viral shedding is most frequent during the first 12 months after infection. Suppressive antiviral therapy decreases symptomatic recurrent genital herpes. Episodic treatment shortens the duration of recurrent genital herpes. There is an increased risk of HIV acquisition even when the patient is asymptomatic but is HSV2 seropositive, when the patient is exposed to a person who is HIV positive. The safety of partners is very important. So it's important to inform the patient should inform the current partners about and any future partners about the genital herpes. Abstaining from sexual contact if the patient's partner is uninfected during the prodrome and clinical infection. Male latex condoms, if used consistently and correctly, will reduce but not eliminate the risk of transmission. And daily valcyclovir decreases the risk of transmission in HIV negative but not in HIV positive partners. The treatment of genital herpes in HIV, the first episode genital herpes, is the same as HIV negative, but it's prudent to extend the treatment till lesion resolution. It's important to remember that suppressive or episodic therapy with antiviral drugs are effective in decreasing clinical manifestations of HIV in HIV positive individuals. In HIV positive, when you start ART, there is a increased risk of symptomatic genital herpes in the first 6 months, especially if the CD4 count is less than 200. And it's prudent at this time to start suppressive anti-HSV therapy for 6 months to decrease this risk. The suppressive antiviral therapy, that's anti-herpes genitalis therapy, doesn't decrease the risk of HIV, HSV transmission to susceptible sex partners. For severe HSV infection, which may be seen in patients who have a low CD4 count, it may be prudent to start parenteral therapy at the beginning itself. Now, these are the WHO, the CDC guidelines, and the likely NACO guidelines. Now, the likely NACO, they haven't been published, so likely NACO guidelines are similar to the WHO guidelines, except that they give the treatment for 7 to 10 days in contrast to the 10 days recommended by WHO. Same holds true for treatment of genital herpes in special situations. The guidelines are similar to the WHO guidelines. Slide about neonatal herpes. So neonatal herpes often occurs in mothers who are asymptomatic, but it's prudent always to rule out genital herpes in all pregnant women. Routine HSV serology is again not recommended in pregnant women. However, it may be done if the patient with genital herpes has a pregnant partner. In that case, you need to do a type-specific serology to identify pregnant women who are at risk of acquiring genital herpes. There is no data to support use of antiviral therapy if the pregnant woman is seropositive but has no genital herpes. So don't start it in asymptomatic patients. What has not been studied is giving antiviral therapy to partners with genital herpes to decrease HSV transmission to pregnant women. This has not been studied, so we don't know what is the value of starting this. Women who acquire HSV in second half of the pregnancy should not only be managed by dermatologists and venereologists, but also specialists from mother and fetal medicine and ID specialists. Now, it's important to prevent neonatal herpes. So it's important to decrease the transmission in the second half of the pregnancy, because that is the time if the mother acquires a new infection, there's a greater chance of transmission to the child. Avoiding exposure of the neonate to the virus. So in women who have signs and symptoms of genital herpes, a C-sec is recommended. decrease viral shedding. So you may start acyclovir at 36 weeks as suppressive therapy. Now, there is recent evidence to suggest that STI PEP and PrEP is effective in preventing bacterial STIs. Among MSMs, doxycycline given as a single dose less than 24 hours after a sexual encounter taken as PEP decreases both Treponema pallidum and Chlamydia trachomatis infections, but not Neisseria infection. Among MSMs, daily doxycycline OD taken as an STI PrEP decreases substantially the occurrence of Treponema pallidum, Chlamydia, and Neisseria gonorrhea infections. But these earlier studies were limited by small sample size, short duration of treatment, and concerns about antibiotic resistance. Now, a 2023 publication, which has pooled in data from 3 open randomized trials, clearly indicates that use of 200 milligrams doxycycline reduces considerably, more than 70% incident syphilis and chlamydial infection. Now, partner management, the newer guideline, NACO guidelines indicate that you need to treat sexual contacts within 10 days preceding the patient's symptoms. Even if the partner is asymptomatic, they need to be given presumptive treatment. In pregnancy, logically avoid ciproflox. In HIV, the recommendation is that you give the treatment till the lesions have healed, and single dose therapies need to be avoided. So partner management in LGV, the sexual contacts within the 60 days preceding patient symptoms need to be examined, tested, and presumptive treatment given to all contacts, even if they are asymptomatic. In pregnancy, azithromycin is given presumptively 1 gram weekly for 3 weeks, but there is no published data regarding effective dose and duration. Now, treatment of pregnant women needs to be finalized with a test of cure at 4 weeks after an initial CT-NAT with positive test. In HIV, you need to give the same treatment, but may need to be given longer. The treatment, the first line of therapy is doxycycline. Now, donovanosis, now a rarity, and more, I think if you see a patient of donovanosis, one would report it. So we actually reported a case of chancroid a couple of years back because it's also become a rarity. Now, in donovanosis, sexual contacts within 60 days would warrant therapy, even though this empiric therapy, the value of empiric therapy in asymptomatic partners is not established. In pregnancy, the drug is our drugs are the macrolides, and in HIV, the same treatment needs to be given. And the treatment of choice is azithromycin 1 gram once a week. Now, not all genital ulcers are herpes, or should I say herpes, or sexually transmitted infections. Now, a word about Lipschutz syndrome, because we recently saw a patient. Now, it's usually a first episode of acute genital ulceration, usually a 20-year-old, young girls, usually deep, well-defined, painful ulcers with necrotic base on the labia minora with a bilateral kissing pattern, absence of sexual contact in the previous 3 months, absence of immunodeficiency. The course is abrupt and the patient usually self-heals in about 6 weeks. Now, there are so many groups now of artificial intelligence. Now, I couldn't resist this as my last slide, the performance of an artificial intelligence computer vision mobile application for the diagnosis of genital dermatosis. Again, Somesh Gupta is at it. So he actually looked at this, and I think there were 5%, 6% of the patients were patients of anogenital herpes. And this app performed better than the primary care provider and was 73% when compared to a dermatologist. Thank you for your patient at 9 o'clock in the night, too late for me. It's
Thank
well
you, madam.
past my bedtime.
But please don't go away. We'll leave you by 10. I request Dr. Deepika to start once madam stops sharing. That's it.
We stop sharing.
Good evening,
When
and
Madam started, it was 110. Now we are approaching 200. That's great, Madam. 200 participants are listening
Double,
to
it's a
us.
Sachin Tendulkar, I can see.
Yes, yes.
so good evening, everyone, and welcome to this panel discussion on a very, different topic, I would say, genital discharge, a case-based discussion in difficult situations. So the important terminology is difficult situation. And I have esteemed panelist, Dr. Mohan Kumar, who's the secretary of IASTD, Dr. Neena Khanna, whom we just heard in an excellent talk, Dr. Rakesh Bharti, who's an expert in STI and HIV, and Dr. S. Murugan, again, with a very deep and very animated, he has an interest in STI and HIV. So I am sure that the inputs from all my panelists would make for a very interesting discussion. So Dr. Mohan Kumar, will begin with you. So what are the common genital discharge cases you come across in your practice? And I'll add
Yes,
the second question. Has there been any change in the presentation in recent years?
yes, sir. Yes, madam. Good evening, all down. My sincere thanks to the West Bengal Academy for giving this opportunity. Once again, I thank our senior most professor in STA, Professor Neena Khanna, when I am the junior most PG in 2001, and we attended the stick on New Delhi in manner, the same as the days Madam rocked once again, Madam. So we said we go to the discharge. Uh, After the COVID only, we are seeing common genital discharges in our cases, Madam. After my PG, when I am working in the same institution for almost 2 decades, we never come across any ulcer or discharges as now in the post-COVID era. So of late, in the past 6 months, we are seeing more number of genital discharge cases. Mostly they are coming into the inclusion. We are coming as a classical case of gonorrhea. We are seeing. We are also seeing the infections which lead to the local complication with the paraurethral and periurethral gland infections. Also, fistula also there. That case is
Complicated.
also presented
Yeah.
in this element. Simultaneously, with the male patients, we are not, they are revealing that identity, they are not going with the commercial sex worker based STI infections. Nowadays, the app based contact is there. So the multiple relationships within their groups, either in the female or male, that's not in, their high risk behavior is increased. So they are practicing not only with the old annual incentive and oral incentive case are there. My institution is situated almost 50 kilometers, say 100 kilometers away from Coimbatore, which is the major city in western part of Tamil Nadu. But we are seeing the pharyngeal gonorrhea and anorectal gonorrhea in the last week. So that's very
That is
highly
a
alarming.
very important message, Dr. Kumar, that
Yes,
basically
ma'am.
it's not just the disease profile, but the epidemiology and the risk factors also that have changed. And this has been specifically, very obvious post-COVID. I agree. We've also started seeing a sharp increase in gonorrhea cases and more MSM behavior with atypical site involvement. And even if you see worldwide, now what is remarkable is that almost 367 are discharges, chlamydia, gonorrhea, and trichomonas. Now here I'd like to specifically ask Dr. Murugan. Dr. Murugan,
Regarding
about trichomonas. Now what you see is that trichomonas is the number one in the WHO estimate. But every Indian study, we hardly see it. So what do you think are the reasons why trichomonas is underrepresented in any STI data from India?
presently, I'm not working in the institution, madam. That is one thing. And another thing, I personally feel trichomonas was very common. Even sometimes we happen to see in the urine of men also trichomonas. But recently, of late, I am not coming across much case of trichomonas in spite of specimens or saline preparations are seen in my practice. Maybe in institutions, I don't know exactly. Now I'm not attached to institution as a retired man.
So basically, what I feel is that we are not using very sensitive tests. and we are not very, the training in detection of trichomonas, we need to work upon, and more highly sensitive tests. So maybe like Dr. Neena talked about ulcer multiplex, we need to focus more on discharge also.
Yes.
And generate more data. So that is one of the, because it is very disproportionate, the world data and data from India when you come to discharges.
Yes,
We are
correct.
probably missing, because it cannot be that it is not there in India. I just think we are not picking it up. So we begin with urethral discharge, case-based. So this is a typical presentation, and you make a smear and you see the diplococci. So it is very easy to diagnose. Dr. Bharti, I mean, if you have a lack of response at 7 days, you give ceftriaxone, and the patient, and maybe if you're giving syndromic, you give doxycycline, and the patient comes back at 7 days, and there is still persistent infection. How would you approach?
Thank you very much, Dr. Deepika, for bringing me in, and thank you very much, IADVL West Bengal, for keeping me as a panelist. Before I answer this question, I want to go back to the last question, that why are the data not collaborating about the vaginal trichomonal? My mind says that probably the females prefer to go to a gynecologist rather than a STD specialist. So that is why probably if we do not involve the gynecologist in that data collection, we are missing patients over there. And of course, you rightly said the tests availability. Like, I'm not an institute, but I am sitting outside in the practice. Institute is right there next door to me almost. But even then, even in medical college, the STD department sees less number of patients as compared to the gynae department. So I think there needs to be a coordination between the two. This is one. Now, second, coming to your case, that if it doesn't work out in 7 days, what do you do? I personally feel that I will look into the history once again. Is the patient non-compliance about not only treatment, even non-compliance about abstinence? If that happens, then there is a problem, number one. Number two, in these days of irrational use of antibiotics everywhere, you can think of some sort of a resistance developing into the person, and you can ask for a culture sensitivity test, to my mind. These two things should be taken care of.
Dr. Murugan, do you have anything to add to that?
Yes, madam. Partner treatment, we have to be specific and we have to insist. That is one thing. Another thing, maybe co-infection, NSU, as associated NSU, that's also be there. So we have to treat both sometimes. So that's also there. And if it is persist in spite of 7 days treatment, and then we have to think of the possibility of drug resistance.
So there is a lot of work going on in gonorrhea for current regimen, because CDC recommends 500 mg ceftriaxone, and there are several new drugs that have come in. I mean, would anybody want to talk about the newer drugs? We personally do not have great experience, but there are several ongoing trials on many of the newer drugs like gipotitacin and on solithromycin and zoliflodacin. So there are several newer drugs that have been tried. So does that sound interesting to you, or you are very happy with ceftriaxone in the Indian scenario? Because we know that ceftriaxone resistance has been reported in, say, some countries, especially in Thailand, Bangkok. So any personal experience that you've had with drug-resistant gonorrhea? Any of the panelists?
I think
Madam,
Dr. Neena
Sudeep,
was saying
yeah,
something.
Sudeep, I think your study, I think at you that time you had one patient with
Yeah.
ceftriaxone resistance.
That is what I was trying to tell.
Yeah.
So
Way
I
back in
remember, and then
2000,
we
we had a
lost track. We weren't able to, take it further. We almost were going to report it, but I think we fell short of the repeat this thing. No, I think Dr. Geeta was your co-guide, I think.
Right.
So, and this was almost 12 years back.
12, no, 20, 22 years back.
22,
2000.
that long back you were my student. Okay.
So as per gifts, we should be monitoring,
All
and
experience and
ceftriaxone resistance is coming up all over the world. And I We look forward to the revised NACO guidelines because now they say 250 mg is not enough. CDC strongly recommends 500 mg even for complicated gonorrhea. And in fact, the combination therapy they say is not required, azithromycin plus ceftriaxone. So, Dr. Bharti, any difference in your approach to managing urethritis if the person was an MSM as
Uh,
compared to an heterosexual?
I really think nothing much except that I have to lay stress on counseling about the abstinence and using of protection, especially uh, besides that, MSMs are not as many as we presume in my part of the country, but still I see nowadays more MSMs than others. Why I don't know, but the trend has
So
increased.
with it becoming legal, they are more likely to admit to the history. I think that has been the game changer after 2018 and post-COVID. There is less stigma attached to admitting the behavior.
Yes,
And personally, we have seen a increase in MSM a lot in our clinic. I don't know about Dr. Kumar if you've seen.
Yes, madam.
Yeah,
In our part of the area, we whenever the urethritis, the MSM activities, we usually screen all the forums, especially the oral cavity, anal cavity, and everything. We
yeah, that
advise them
is
to regular follow. That's the
very
key
important.
in the
Yeah,
MSM, madam. In the treatment aspects, when we are treating a urethritis in the heterosexual, we usually go along with the treatment of trichomonas vaginalis, whether it's the female partners having the trichomonas infections. So
so
that will have
co-infections
a
in
good value to reduce
heterosexuals.
the resistance pattern.
Right. So what you said is very important because it is said that hidden or missed pharyngeal infection with gonorrhea is one of the most important reasons for promoting resistance. So that is a very important message. I have seen even in my institution many times the residents forget to open the oral cavity and you can see the obvious infection in many of the MSMs. So the kind of contact is also very important, but again, you should screen all sides. So this is a 15-year-old boy who presented with multiple tattoos, self-inflicted. And he was what is known as he had multiple contacts. He was with both the heterosexual as well as same sex. And he had herpes come this discharge. So he had both. And he didn't come for this. He came for some acne or something. This was a cry for help, I would say. And he came all alone. And when we did gram stain, we saw Neisseria gonorrhoeae, diplococci. So pediatric cases of urethritis, how often do you see? I mean, Dr. Bharti, do you see it in your private practice?
not
Yeah.
very often. Not
Dr.
very.
Murugan, what about you?
Not, madam. Very rarely I have seen one or two cases, but not recently.
Right, Dr. Kumar?
Yes, madam. We have seen a case, similar such case, but not that 15 years old. But in my institution, just before that, as Astikan, Calcutta, we have seen Tom Gale. He came to us with the introductions that I am a Tom Gale nearby Tirupur metro city. I am living there. My family is like this. We are migrant population, like that. They are telling that. But he done outside with the VDRL testing and TPHA testing along with the acneiform eruption only she had. Nothing else he didn't have. She just came with the
So he
report that
came
he
actually
had
with his
gas.
partner. He came with
Yes,
his
sir.
partner. He brought his partner along. So two
Yes.
adolescents came together.
Adolescents,
So
yes,
we
sir.
need
This
to
also there, sir.
remember that
Yes.
10% it is what is known as it is voluntary sexual activity rather than abuse always.
Yes, madam,
And
definitely. This type of people is going like this, madam.
so what I must say is that consent is very important in pediatric cases. Below 12, you need parental consent. And above 12, even the assent of the patient is good enough. And you need consent for everything. What I'd like to tell the dermatologists, especially for taking photography, like the photographs that I am showing you, you have to be very specific in taking consent before you take such photographs. So this is like you should have a formal, we have in our institute, especially with the one-stop center. But what happens to the boys? One-stop center is only for the females. Have any of you faced this, Dr. Kumar? Where do the
No,
boys go?
madam. Boys, we didn't have that one-stop structure in our part of the country.
No, that is not, it's not there anywhere
Yes.
in India. One-stop
Not,
center is only for females.
Yes,
So
madam. We
what
didn't
do the
have for
boys
the
do?
females, madam. It's only whom we are they are having.
So we actually have, you have to report it, we know, under the POSCO Act. So this is a
Yes, madam.
challenge, and I think each one of us should devise some ways of reporting the boy, especially if you suspect abuse. So consensual check is above 18 for males and females. This is important for us to know so that you detect abuse and report it. So again, test and treat for STIs, counsel and follow up. And ideally, only NAT should be done for pediatric because of the medico-legal, and post-exposure prophylaxis is beyond. What about Dr. Murugan, other causes? Do you see children with other causes, non-STI child, where you may wrongly label?
Yes, I have seen cases of superficial discharging, especially congenital phimotic cases. So the children also have come, and also adults also. I am coming across so many cases of superficial discharge, either congenital phimosis or sometimes even inflammatory phimosis secondary to some other STI. For example, warts or ulcers or some other even uncleanliness, balanoposthitis. All these things may put together, and patient may have come up with a discharge, profuse discharge, and it is offensive and frothy discharge. It is not coming from urethra, so we can. So that is a thing we have to give importance to that.
And even in pediatric age group, sometimes ectopic ureter, hypospadias and all this, that also sometimes may erroneously be sent to STI. So
Yes.
in pubertal children, it's similar to adults. Complications can also occur, but you also should look out for pharyngitis and proctitis, just like MSM. So here is another patient.
Deepika, just 1 minute.
Yeah.
Kingshuk has entered now of late. He had some
Right.
issues in his own housing complex.
So I
Now
will,
he's entered. Just to inform
include.
you.
So this was a patient I reported when I was a senior resident. So he was a 18-year-old. He had multiple contacts. So who would like to take that up? Dr. Murugan or Dr. Nina?
So it could be possibility of water can perineum.
Right.
Secondly to post-urethritis and stricture. Sometimes there is a chronic cases. It may lead to water can perineum, madam. Complicated chondria.
So I think Dr. Mohan reported that after COVID, he's again started
Yes,
seeing
madam.
complicated cases of gonorrhea. So I think this is why I put this, that it's a reminder, like syphilis, where complicated syphilis is coming back, tertiary syphilis is coming back, even complicated urethritis, and in the case of PID and other complications in women are coming back. So we have to revisit all these things that were there in our textbooks, because it's starting to present again. So we all know the management as per CDC. This is a case from Dr. Murugan. Dr. Murugan, what you were talking about. But how will
Yes,
you
madam.
manage such a patient?
Actually, this the patients I can demonstrate the fusus spirochetes in this specimen, madam. Just saline preparation. We can see it under microscope. Fast moving, that is it. Porubrillial organisms should be there, and if we are there, it is there. We can give either Perkin penicillin, but Perkin penicillin is not available. So I will use to put on amoxicillin 500 milligram 3 times daily, along with metronidazole 400 milligram 3 times daily, because it's a anaerobic organisms also will be associated. So we have to treat both. It is a very common secondary to some other STI. So this is a very common thing. And if we are giving the patient will respond within 7 days. So if it is inflammatory phimosis, the phimosis also will be resolved, and then we can see the real cause for the STI, and we can treat it that. So this is way we have to approach, madam.
Dr. Nina, what have you found to be most common when you see such kind of phimosis? Ma'am?
In the corporate sector, we don't get to see.
But in AIMS, New Delhi.
AIMS also, I think for the last decade or so, we've not seen this. My main exposure to STI was in UCMS, my
Right.
brief stint there. And you were showing us those pictures of children. I think you would recollect,
You
Dr. Pandey,
reported,
we
yeah.
published a series of STIs in children. But
Right.
in EAMS, we don't get to see. I haven't seen this sort of.
So that reiterates Dr. Murugan's point that poor hygiene is the main thing. So you get better hygiene patient in AIMS.
That's also there.
Right. So
Yes.
instrumentation sometimes may be a cause for discharge, like in this HIV positive MSM, 16-year-old. He had Bushke-Lowenstein, and because of that, he had decrease in his urine stream, and he was catheterized. And so the discharge was secondary, you can introduce an infection. So coming to vaginal discharge now, this is what you typically see. And recalcitrant discharge, how do you approach? Dr. Bharti, I mean, do you see a lot of, vaginal discharge that do not respond to standard NACO treatment, syndromic treatment?
Many times you have to look after the partner also. And
Right.
nowadays, what I am seeing is, we miss in taking the history. We are male dermatologists, especially, are sometimes shy to ask the various. Madam Nina was talking about 5 Ps. We forgot about the partners.
Mm,
Just think that must be one partner only. This is one thing.
right.
And very common answer when I ask some people here is that I don't have extramarital relations except somebody who is only speaking to me. And when you go further, you realize that only one is married, and then the married partner is, you know that geometrical proportion it can go on to. So one of the reasons is we miss in the history something. You come across such cases, you have to redo it. Number
Right.
one. But the
So
other
you see this purulent discharge. Is there anything else you see, Dr. Murugan?
Ulceration is also there. I can
So, but
see.
you have an IUCD. So you can see the IUCD thread.
Yes,
Oh,
madam. The
So
thread is there
what
in
do
front.
so what do you feel about IUCD? So this actually is a very interesting patient. If I'll tell you the background, she was a patient of pemphigus. The IUCD was advised by us because of the immunosuppressives that she had to receive. Her first smear showed this. So I don't know if you can see, and she was diagnosed by the resident as Neisseria gonorrhoeae. Partner was treated, she was treated, but the discharge persisted 7 or 8 times. And if you see, what do you see? It's not diplococci. When we saw the smear again, it's actually the coco bacilli, and it grew as a Acinetobacter. So the message is also that, especially in immunosuppressed, we must do a pus culture. It is, I always tell my residents, for PID, look for PID, do an ultrasound and do a simple pus culture in addition to an STI screen. So the question basically I want to ask, would you remove the IUCD? Because she was not
definitely.
responding
Yes,
to
madam.
any.
Definitely, we have to reduce the remove the device, madam.
Otherwise, the
Absolutely.
infection may go up and produce some salpingitis and other things. We have to remove.
Yeah, because theoretically the risk of IUCD is one person with copper IUCDs, non-hormonal, non-levonorgestrel IUCDs, and it is said that the acute effect is for 3 weeks because you introduce the organisms from the vagina when you are inserting the IUCD, and the risk decreases after 3 weeks. So CDC recommends that you try, and in fact, the studies have shown that there's not much difference whether you remove the IUCD or not. But generally in practice, we do remove, I agree, especially if the patient is not responding to treatment. So this is what Acinetobacter actually looks like. It retains its gram positive. So Dr. Neena, would you like to take this up? So you see the sturdy white discharge, ma'am, and you see the candida pseudohyphae. Recurrent VVC, what is your approach, ma'am? I mean, how do you manage recurrent VVC?
The first is that you start giving. I usually give them weekly fluconazole, and the recommendation says that you don't. If you're giving weekly fluconazole, you don't need to really give them topical therapy. But in some patients, I do add because they have a lot of vulval itching. So I usually, after the first dose of fluconazole, I usually give them a combination of antifungal and a mild steroid to symptomatically improve the patient for 2 or 3 days.
Right.
If, however, the patient after 4 weeks continues to have the discharge, then you are looking at maybe a non-albicans candida infection. And then I usually ask the patient to get, I send it for culture.
Okay, so you answered the second question. Does the species, so do you think, the recommendation is give alternate days and then weekly for 6 months.
Yeah.
What about itraconazole? Do any of you prefer itraconazole over fluconazole in this scenario?
I haven't used much of itraconazole because I just reserve it for dermatophytosis because that's the only thing which the patient responds with tinea. Tinea
It is
patient.
part of the recommendation, ma'am. Kingshuk, do you do a culture for Candida in cases of recurrent VVC who are not responding, especially?
No, ma'am, actually, it is not available in our
Right.
hospital.
Anybody else who does a culture for VVC, especially recalcitrant VVC or recurrent VVC?
Before culture, madam, recurrent VVC, I want to rule out all the predisposing factors.
Right.
Diabetes, broad spectrum antibiotics, steroids, immunosuppression condition, pregnancy. So that's also we have to rule out. And also I want to examine the partner. And as a last resort, I may sort for fungal culture to
Right.
see that. That's the thing.
Again, this is
I
a
want to add-
patient of systemic sclerosis who was again on
Can I
immunosuppressive.
add one thing to the previous slide?
Yeah.
The patient, diabetic patient who is on deflazone can develop recurrent candidiasis in males and as well as females. We have to take care of the drugs being taken for diabetes.
Antibiotics, that's what Dr. Murugan.
No. Deflaglolazone, I'm misspelling maybe. They hypoglycemic agent.
Okay, so anti-diabetes, he said diabetes.
It is very commonly causing.
Right. So this was a patient of systemic sclerosis, a young 27-year-old who had, so you see she was also treated for gonorrhea, but if you look, you see the pseudo-hyphae. And this is what her report came out as. Candida glabrata, and you see the sensitivity, it was totally resistant to fluconazole, what that we were giving to her, and it was less sensitive to ketoconazole and itraconazole. So in fact, we in our institute do a lot of cultures in people who do not respond. And in recurrent or persistent VVC, we do cultures and it does help us a lot. So this patient was switched to itraconazole and she did respond. So a pediatric patient.
In recalcitrant vaginitis, there is a non-candida albicans. We can try boric acid intravaginal capsule, madam.
Right.
That is
Right.
available online.
Right. Online it's available.
Yes.
And there are several newer molecules that are coming up like abraxane. There are and some newer azoles also like what is hexanazole. So there are a lot of new molecules in STI currently. So this is one of the phases when new drugs are likely to be available.
Okay.
I was talking about this drug, dapagliflozin.
Okay. Thank you, sir.
Used for latest drug in pediatric patients.
So this was gonococcal vaginitis. Dr. Nina mentioned about pediatric series. So again, pediatric cases we talked about. So this was our series. So you see, it's almost equally prevalent in girls and boys. So that is one of the myth that we should always remember that pediatric STIs do not occur only in female. Boys are equally, if not more, abused than girls. And prepubertal children, mostly they are symptomatic, whereas in adolescent, complications like ascending infections are more common. But what are the sequelae? Do you think children, especially like this girl, beyond just the ascending infection, which is unlikely in her because she's prepubertal, have you seen any sequelae in female or male children who are abused? Dr. Mohan?
But so far we didn't seen that pediatric abuse in our part of the country, madam.
Yeah. So that is very interesting. I don't know why it's only a North Indian phenomenon or they're going somewhere else. That is the main doubt.
Probably early treatment occurs here, madam.
Okay.
ulcerative and warts have been seen often with abusive rather than gonococcal vulvovaginitis, madam.
Right. So there are a lot of psychological, physical, behavioral, and interpersonal. So this is why a child with abuse, we should follow up and needs a lot of social support. And that is in females. That is the aim of the one-stop center. So we know about POSCO, and I just wanted to highlight that 6 months jail if you do not report. So that is another thing we all should be very careful about if we detect. Dr. Neena, ma'am, will you like to say what all will you consider in this young child?
Candida,
Candida. So
because
you'd
there
like to take a
is
smear for
maceration there,
right,
and there also flexures are showing the whitish maceration.
right. So this actually is a report where she drew Streptococcus pyogenes. You can have it in perianal also. So the discharge may be not an STI. This is very important, especially in pediatric, because wrongly labeling a child as abuse has as much harm and stigma as missing abuse. So we have to be careful in evaluating a child who you might suspect of abuse. So again, this was a case that Dr. Neena showed. So you see a discharge is secondary to the ulcer. So this is Lipschul's ulcer, and this is Bessett's. So we must look beyond STIs also. All discharge are not due to STIs, and that is why you need a proper etiologic diagnosis many times. So this was a pemphigus again. So the discharge was due to the prolapse that happens many times. I think Dr. Bharti mentioned gynecologist. So here we would refer it back to the gynecologist because of the uterine prolapse. So this was actually a patient of pemphigus, and the erosions and the maceration due to the prolapse were the reasons for the persistent discharge. Do you routinely advise pap smear? Doctor, any of you can take it. In patients who present with discharge, we all would advise it for warts, but what about discharge?
In our part of the country, by all the reproductive age group people, madam, we are doing that pap smear as a part of our screening program, because in my district is concerned the endemic for the cervical and breast cancers. So all the patients
So
who are coming to our
all
OPD,
STI women presenting with discharge through the STI clinic,
yes,
you
madam.
get a pap smear.
All reproductive age group people, all reproductive age group, whether they are have gastric infections or
Right.
dermatologic infections, we are doing the screening, madam.
Kingshuk, do you also do that?
Ma'am, not routinely, but those cases which are referred to our Suraksha clinic, and those have diagnosed cases of STI, yes.
Right. So the STI clinic, you do a pap smear for beyond HPV. The traditional teaching was only for genital warts we used to earlier do, but this
Yes.
is what you see LSIL, HSIL, and reactive. So in our study on 90 patients, we saw 41% had LSIL and 1.1%, that is 40 patients had, and presence of chlamydia, not only of HPV, but presence of chlamydia also significantly increased. So the idea is HPV, of course, you need to treat and you cannot eradicate, but chlamydia you can treat and decrease the chances of dysplasia. Now, the last part of it, Dr. Bharti, if you have such a patient coming to you, how will you approach?
I think number one, I would try to find out what is their stained discharge and know whether it is gonococcal or what, right? And there are multiple sinuses all around, right? So even a culture sensitivity will be a good idea to do before I even venture for treating him as a gonococcal patient. The other thing is we will definitely do all the seromarkers because he's MSM, and even for herpes, I would like to rule out that is there a, so all sorts of STDs we will have to screen in this case. Number one. Number two, I think then of course we can treat accordingly as per if it turns out to be only gonococcal, then ceftriaxone. You were telling 500 is the now standard, but otherwise
No, we are waiting for NACO. They are coming out with the guidelines this year. Let's see if they revise that 250. So as of now, NACO is 250, but that's the CDC 500 mg.
I think that should be my approach.
Right.
But in this case, madam, I'm
Yeah.
able to see some furuncles or small swellings or redness are there. So fistula, more like a fistula, and and we have to see it, state the smear, and we can whether it is gonococca is observed, we can or culture, we can go for culture. And we can,
He was culture positive, so that is one of the points for rectal. He was gonorrhea. He had Neisseria gonorrhea on smear
okay.
as well as culture. He was seropositive. And would you do this? When do you any of you do this routinely? Proctoscopy in these patients.
Proctoscopy, we are doing it, madam, for the patients with the asymptomatic patients with the history of any ulcer, any things that we are doing it, sir. But patient usually the anal laxation, they will not have that much pain, madam. So we are doing it, madam. Only
Yeah,
not
because
in
he
the
was a
acute case we are doing it.
MSM. He had a very lax opening, so it's
Yes,
pretty easy to do. You lubricate it and you use it, so it is pretty easy to do. So this is just from CDC. It is clinical approach of STI or any discharge in an MSM. It is actually a lot of points you have to say. So we should be careful now so that we do not miss anything as well as any source of infection. If there is any other site involved, the patient may continue to transmit to the partner. So careful history and proctitis like this patient. So you see Neisseria gonorrhoeae, chlamydia trachomatis, even T. pallidum, and it is pretty common. So how do you diagnose? Do any of you use PCR? Is that available to you? That is one of the biggest challenge we have in our developing countries. Because the
Yes, madam. We didn't
recommendation
have
is
it
to
in our
use
center.
that, right? Dr. Neena talked about her institute, AIMS, that is available. But it
Yes.
is usually not available, I'm sure, to Dr. Rakesh Bharti in his, or do you refer to Ranbaxy or some other private lab and get it done?
That is the only way we can do it.
Right. So anybody uses NAT for diagnosis?
Not
Not
available
yet,
now.
madam. Not
Not
available.
available.
Very difficult
These
to.
are the challenges in the Indian scenario.
Yes,
Yes,
madam.
madam.
So ideally, as per recommendation, you should be doing that from all three sides, especially if there's insertive, urethral, rectal, pharyngeal, and LGV biovar. Do you think LGV is important in, any of you have some experience with LGV in MSN?
Yes, madam. In our part of the country, that in one year before that, our Madurai collector serum is reported in case of LGV in the some part of. So it's also in the
So I
rising
just
trend.
wanted to highlight a study. Somebody might be thinking I'm impinging in Dr. Neena's topic. We are talking about LGB, but one of the very interesting studies is from Europe. It's a multi-centric study where they took chlamydia positive. So they were diagnosed as chlamydia from the proctitis. They took the sample and they were they were chlamydia positive. But when they retrospectively saw almost more than 1/4 were actually LGB. So there was a discharge due to LGB, which was wrongly treated as chlamydia. So the ramification is that they were undertreated and they continue to develop LGB symptoms, and we know the tertiary stage and all. So this is one of the message that it is very sad that none of us have NAT available and we may be missing a lot of things.
Yes, madam, definitely.
Right.
So you have two NATs, you have the species specific and
Right.
the generic
Group
one. I
specific.
mentioned that.
Group specific. So that's what, ma'am, I said you had that advantage of working with that multiplex. So you could identify HSV1 and 2 separately. So this is the message that you don't need group specific, you need the species specific because you may be underdiagnosing, for example, LGV. So one of this very interesting is proctitis, even self-collected swabs. Have any of you ever used self-collected swabs from your patients? Especially from the rectum, some patients may feel a little hesitant to come to the doctor. None of you
Madam.
have ever
None
used,
of us.
right. So this is syndromic management of acute proctitis. So this was not part of NACO standard So it is ceftriaxone if you see 500 mg. And if you have bloody discharge, it is presumed that it is LGV, or if there are ulcers, and give doxycycline 100 mg for 3 weeks. So that is what I'm saying. If you are treating only for chlamydia, you are under treating those patients, not for LGV where you need 3 weeks. So management of sex partner again is very important. So I want to ask all the people who are working with MSM, how many of the MSM get their sexual partners?
Usually they are not coming with the partners, madam. Sexual partners, they are not coming. They are also not treating that, madam, because if they are telling that I am infective, that partnership relationship will be that lost. So they are not
And anyway, you
ready
spoke
to.
about sometimes they have what is known as chemsex. The network is somebody they may not know. They actually genuinely may not know.
Yes, ma'am.
Dr. Murugan, anything?
But my experience says that majority of them come with their partners.
Okay, that is very
But we are
interesting.
able to convince some patients who are educated and who is understanding. We are able to convince them and bring the partner, madam. That's also possible.
Right. So many times the treatment failure may be like all of you have been saying, if the partner is not treated, it may be part of abuse again, because you can look out for abused children, the anal discharge and anal involvement. That is one of the message. Anal cytology, do any of you do anal cytology in such patients? No?
Oh, no, madam.
No, madam.
Not.
So it is part of recommendation that you should do anal screening and high resolution anoscopy. Give a quadrivalent vacancy. These are CDC, because the inside information is NACO is now going to come out with approach in this version for MSM and TG. So this is one of the things we can look forward to having included in the present NACO recommendation, and vaccination for hepatitis A and B. So in our experience, we found a pretty high incidence of anal dysplasia in MSM, and especially in transgender, and even in women. But I'm not talking about women now. At least I think we should begin with MSM and transgender. And we were talking to some people in NACO, and they said this is what they are trying to do in some, selected intervention groups. They are doing studies on anal cytology and intervention.
Dr.
This
Deepika,
is what it
3 more
looks like.
minutes. We'll wrap it up then.
Yeah, we are wrapping it up.
Okay.
So, pharyngeal involvement, is it genital discharge? Should we talk about it? It's not traditional genital discharge.
Yes, madam.
See,
So
what
It's
you
that.
like to-
happening these days
Related to genital activity.
era of these massage parlors,
right.
most of the people come back and they think ratios, something which is very, very safe. Then they end up with things like this.
So the message we want to give collectively, it is part of genital discharge, even
Yes,
though
ma'am.
it is at a wrong place, but it is part of genital discharge, and it is a site that we must remember to swab the posterior foramen pharynx. So any take-home message from any panelist?
So my take-home message for this panel team is, whenever we are seeing any discharge, we have to examine all the cavity, oral cavity, genital area, and anogenital area. We have to look for other ST infections, treat all the mixed infections simultaneously with the partners also.
Right.
Remember all the P's, as Dr. Nina said.
Okay. Dr. Murugan?
And we have to test for other STIs also simultaneously. That's also very important, madam. And partner treatment is very important. And sometimes non-STD cause also can produce genital discharge, like especially females, foreign bodies and other things, secondary infection, and any presence of any ulcer. That's also we have to give importance, and we have to look for that also, madam.
One patient who is a doctor who came to me with bloody discharge, and it ultimately pox in the epididymis.
Okay. So look for other causes. Malignancies
Eyes
also in women. Malignancies
Yes.
in women can also present with genital discharge. So we always need to remember that something that's
STI
not
causes.
improving. Dr. Nina, ma'am?
I would like to repurpose the COVID PCR machines to
Exactly. I agree with you, ma'am. We need to now start talking about etiologic diagnosis and more effective, more scientific, and with the coming down of costs, this would be something we all would be using in our practice.
We have so many PCR machines lying idle
Right.
now.
Now, even the commercial PCRs that you mentioned, their price has come down significantly. So I think in the future we will more, next time we talk about this, we'll be talking about Indian data with etiologic, hopefully. Dr. Kingshuk, anything before we wind up?
Yes, ma'am. I think from the discussion, it is important that we look for other organisms rather than the typical one if it
Right.
is clinically suspected for recurrent cases.
So you can follow the CDC guidelines, and I would invite you for ASTICON in New Delhi. So please do join us, and we can talk more about these things in detail. So thank you again to all my panelists and to IADVL West Bengal for the invitation. And again, we apologize for exceeding our time, and that is because I couldn't see the clock.
Thank you. Excellent panel discussion. Now, Kingshuk, you wrap it up the program and give your vote of thanks. And
Thank you.
Thank you.
On behalf of IDVL West Bengal, I am so glad to be a part of the episode 2 of our Dharma Adhyayan, a brainchild of Dr. Kaushik Laidi, our president, and Dr. Sandeepan Dhar, sir, our incoming president, and of course, the academic chairperson, Dr. Sudip Das, sir. I express my heartfelt gratitude to Professor Nina Khanna, Dr. Deepika Pandey, ma'am, and all our esteemed panelists, Dr. Mohan Kumar, sir, Dr. Rakesh Bharati, sir, and Murugan, sir, for their insightful inputs. And last but not the least, at this late hour of Sunday night, we have more than 140 odd participants, which is very heartening for a topic like sexually transmitted infections. And thank you, Paulson's Dharma, for their wholehearted support regarding the technical logistics. Thank you all.
Thank you.
Thank you.
Just a
Thank
short
you, everyone.
announcement. Just a short announcement. We'll be having the 3rd episode of Dharma Adhyayan on 21st April, and that the topic will be on dermatopathology.
Oh,
Thank you.
great.
Very good.
Congratulations. No, just congratulations, everyone, and thank you for attending. All the seniors like Dr. Murugan was there. It was, thank you, sir, for attending this.
Thank you.
And Dr. Bharati, sir, for the room where we were there, your famous room. And everyone, Madam Pandhi, and also Madam Khanna, and Dr. Kumar, everyone. Thank you very much for being our guest, though in a virtual way. And not just 140, actually, we had 500 participants attached to Zoom. Number one. Number two, in the IJD platform, there were 150 attending live. In the IIDVL West Bengal platform, all our members were watching, and also on the IIDVL West Bengal YouTube channel, a few hundreds were watching. So after 48 or to 72 hours, we'll be able to accumulate all this. It is much more than 1,000 already. Thank you very much. Thank you.
Great.
It is tremendous because
Excellent.
STI,
Excellent.
you made it. This magic was only because of you panelists. Thank you so much. Thank you.
Thank you.
Thank
Thank
you
you.
all.
Thank you
Right.
very much.
Bye.
Thank you. Thank you. Bye.
Thank you.